So, my name is Jesse Gutnick. I'm from beautiful Cleveland, Ohio. And how do I advance this?
Oh dear, I still live.
Oh.
That's an old trick.
That's a dirty trick right there. My disclosures are first that my opponent has significantly more one anastomosis duodenal switch experience than I have. I'll also disclose that I've been asked to argue this point to the death, regardless of my yet to be secret personal beliefs. One comment, I think the fact that we're using this terminology of one anastomosis DS shows how far this procedure has come in terms of its respectability and the data that's being published recently, and I think that this means that it's a great time for a debate. I'm going to present three arguments. The first is how my dad buys a car. The first is the Roux-en-Y versus B2 debate. Because you kind of got into this pylorus question. And then I would urge people to not skip the easy part. So, some terminology. The biliopancreatic diversion with duodenal switch is a 2 anastomosis. The loop DI with a gastroplasty is a 1 anastomosis. And of course, the Demister DS is the OG DS. I was hoping for at least one laugh from that.
Original. I got it.
Okay. So how does my dad buy a car? So when I came up with this argument, I asked my dad to send me a photograph of himself in front of a car that he's owned. And he looked really hard, and apparently he said this was the only one he could come up with. And I think that this is the perfect picture for the point that I was trying to make. So he is standing in front of, if that's what you want to call it, a Land Rover Defender. Now these things were built the same way for years and years. These have been built the same way for about 4,000 years. So they were worldwide. People could work on them. They were very reliable. Even if they broke down, you knew how to fix them because they'd been around and you knew what was going on with them. And he always said, don't buy a car in the first year that it's come out, because let somebody else figure out the problems, and you buy it a couple years later when they figured out that the valves are wrong or some kind of spring was no good. I would say the one anastomosis isn't even a new car. We don't even have a brand name for it. Is it the SIPS, the SADI, the SADS, the Loop, the Omega? We don't know. And so, she went through a lot of the recent data, and I think if you want a really good overview, actually my opponent co-authored a really great review of it, but I'm going to summarize my take on it. It clearly is effective, certainly in the short term. There's somewhat less weight loss and comorbidity resolution. We don't know about weight regain. It hasn't been around long enough. We're starting to see with the sleeve that there's weight regain. We don't know where we're going to get with the loop. The limb lengths measure, so it's a little bit hard to compare the brands. But I think most importantly for this argument, all the differences have to do with the difference in the common channel length, not 1 or 2 anastomoses. And that's what our question is. What's better, 1 or 2 anastomosis? So that brings us to the Roux-en-Y versus B2 debate, the 1 versus 2 anastomosis debate, because it really is kind of a B2. And this is not a pylorus. This is a Heimlich valve. This is a one-way valve. The pylorus is not a one-way valve. We know this from doing preoperative upper endoscopy on patients with normal stomachs, and you see bile reflux in normal patients. The pylorus is not a one-way valve, so there has to be some bile reflux. The original DS was designed as a bile diverting operation, and if you look at Demister's paper, it's described for complete bile diversion, it's non-oral surgenic, and it preserves gastric emptying. And the duodenal switches too, but more importantly, compared to many of the classic Roux-en-Y versus B2, which a lot of that developed in the cancer literature, these patients live a really long time. And we have to think about bile reflux and not what its effects are over 2 years of research, but over a 20-year-old's lifetime who will hopefully live into their 80s. So this is one example of bile reflux in a patient with SIPS. So you can see on the left-hand side of the screen his stomach. It's full of bile, looks almost like a regular sleeve patient. He has a really nice, beautiful pylorus. And then there he has a very nice loop anastomosis. When I did revisional surgery on him, he had really good SIPS anatomy, a 300 centimeter efferent limb. He'd had the ligated right gastric pedicle that a lot of the people that do a lot of STIPs talk about. They say that it drops the duodenum down, so somehow the straight pipe prevents the bile from going straight up into the stomach, apparently. And he had that, but yet look at his stomach. Interestingly enough, I didn't operate on him for his bile reflux. I operated on him because even with the 300 centimeter efferent limb, he had severe protein wasting and needed his common limb lengthened. So it happens with both operations. So what's the classic debate? So the Roux-en-Y is quote unquote more work. There's no bile reflux. The GJ leak has lower consequences. The B2 and the mini is faster, no question. You do get bile reflux. You can get afferent loop syndromes, which are a real mess, and leaks are higher consequences. To really look at some data for how much bile reflux you get with an intact pylorus, I think you have to go back to the pylorus preserving Whipple procedures. And they have done studies where they look at and they're cited here, where they look at the radionucleotide tagged bile, and they see how much reflux is back into the stomach. And to be fair to my opponent, there is some pyloric function. My real question, of course, of these is how long are you really following up Whipple patients? The reason I went into a residency thinking I'd be a hepatobiliary surgeon and I became a bariatric surgeon is I was so depressed by the lack of one-year follow-ups. And so, you know, I don't know what the long-term follow-up is, and we're operating on young patients. I'll also say that the pyloric preserving Whipple has a normal stomach, whereas we're doing a gastroplasty of some type, whether it's a very narrow one or a wider one, depending on how it's done. And just like we've been hearing so much in this conference about the consequences of sleeve and reflux, I think by not diverting bile, we're going to the same camp of sleeve with reflux when we could totally avoid it. So that brings me to my last part. Don't skip the easy part. So I have no data to back this up. I don't know of any paper looking at the cognitive workload of doing different parts of a duodenal switch, but I can tell you that it's a higher cognitive workload for me doing a duodenal section and the duodenal ileostomy than is doing the ileoileostomy, which is a relatively straightforward small bowel to small bowel anastomosis. You sort of do your duodenal section, you do your DI, then you relax and you say, okay, let's finish this up and do our small bowel anastomosis. I think that cognitive workload goes way up when you have to not just make sure that it's open on one side, but make sure that it's open on both sides to avoid that afferent loop syndrome, which in an acute setting can cause a leak of your duodenal stump, or in the chronic setting, perhaps some of these more severe bouts of bile vomiting and reflux from a slight kink there where you get that classic buildup of bile in your efferent limb. And with that, thank you, and I look forward to discussion.